So severe acute malnutrition, it is defined by a very, is my voice breaking? Am I audible? Okay. So severe acute malnutrition, it is defined by very low weight for a child in respect to their height. Okay, by severe wasting. Wasting means muscle wasting. Okay, how do you identify wasting? You see a child who is so lean that you can actually see their bones, the skeletal structure of their body. That's what we call as severe wasting. Okay, or by the presence of a nutritional edema. Okay, edema means swelling, overall body swelling. Okay, so there are two different types of severe acute malnutrition, actually three, but majority it is two: kwashiorkor and marasmus. We'll come to that. So there are classical symptoms in both these disease conditions. One has severe wasting, in which the muscle protein is completely lost, and you can actually see the skeletal structure of the child. Okay. The second type of severe acute malnutrition, that is nutritional edema. Okay. In that, the entire body is swollen up. Okay. So how do you identify it? Like it is very subjective, but still, what criteria do we have to identify that a child may be having severe acute malnutrition? First is the middle upper arm circumference. Okay, what you have to do here is, so these are done in infants. Okay, in infants, in kids who are less than 1 year old. Okay, so take the measurement, take the length of the shoulder to the elbow. Okay, find the length of the shoulder to the elbow first. Then find the midpoint of that length. Okay, page number is 155. You take the measuring tape, find the entire length of the upper arm from shoulder to elbow. Okay, and then take the mid arm circumference. Okay, that is the point which is in middle, the point that is in middle. Okay, that is mid arm circumference. So you take the circumference of that midpoint of the length. Okay, so if the circumference is less than 11 centimeter, if it is less than 11 centimeter or equal to 11 centimeter, it means the child is undergoing muscle wasting. Okay, the child is undergoing malnutrition. Okay, so that is what we call as mid upper arm circumference. A very clinical way of judging. Even the nurses can do this from the PHCs, PHC, primary health centers, sub centers. Okay, even though there these anthropometric measurements are done. Okay, to identify in the initial stages that if the child is malnourished or not. Okay, specifically in rural areas. Now coming to the classification of severe acute malnutrition. Clinically, we have severe wasting that you can see here in marasmus. These are the two major types of severe acute malnutrition. One is kwashiorkor, second is marasmus. Okay, in marasmus, you can see there is severe wasting. The child's entire skeletal system is quite prominent and it is visible. Then we have nutritional edema. You can see here on the second picture, picture A, kwashiorkor. The child's body is swollen up, specifically the abdominal region, the lower part of the extremities. Okay. And what are the medical complications of severe acute malnutrition? There are two types. One is uncomplicated and one is complicated. Okay. In uncomplicated, there are no signs of any infection or there is no indication that the child has to be admitted in the hospital. It is uncomplicated. You can manage with nutrition at home itself. Domiciliary care can be given. No need to admit the child in the hospital. In complicated SAM, that is a life-threatening condition. Okay, here the child may go into a stage of hypothermia, severe dehydration, okay, severe anemia, lack of appetite, etc. Initially, with low protein milk-based feeds, etc., is given. Okay, so that is complicated. You cannot register these cases at home care. You have to admit the child. First, you have to take the child out of the life-threatening conditions. You have to admit the child in PICU, pediatric intensive care unit. Okay, in PICU for first 1 week or first few days, care is given, and then the child is shifted to general wards, and from there on, other form of nutritional care is given. That is complicated, severe acute malnutrition. So what is the difference here? It's uncomplicated. You do not have any clinical symptoms that may indicate hospitalization. Okay, but in complicated, you have specific symptoms. Symptoms are mentioned on page number 156. You have sleep disturbances, metabolic disturbances, infection, because immunity goes down. The child does not have nourishment. Immunity goes down. Child is prone to a lot of infection. Okay, hypothermia, which is life threatening. The child loses the body temperature, organs may shut down. Okay, so that is hypothermia. You have to keep the child in the warm environment to bring up the body heat. Vomiting, dehydration. Okay, these all are life threatening conditions which requires medical attention, hence the hospitalization. Now coming to the clinical features of marasmus. On page number 157, you will find similar features. Okay, order may be different in which it is given in the textbook. So in marasmus, you can see it is seen in kids who are less than 1 year old. So marasmus is very common if there is a malnourishment issue in a child below 6 years of age. Okay, most of the children who are below 1 year will suffer from marasmus, and if the child is above 3 years, 3 to 6 years, okay, in that case the child usually suffers from kwashiorkor. Okay, that is the general criteria we have seen so far. Okay, so due to low calorie intake, why this happens? Due to low calorie intake, growth retardation will be there because there is no nutrition, no growth and development. Severe reduction in body weight because the child has lost most of the weight in muscle wasting. Sunken abdomen, subcutaneous fat is not preserved because the body does not have enough amount of food from outside. What the body does, the body goes into a state of catabolism. Okay, what does the body does in catabolism? It breaks down its own protein, it breaks down its own fat to meet the requirements of the body to survive. Okay, that's the reason why in marasmus you see severe muscle wasting, that is protein is gone. First of all, the glycogen will go from the muscles, glycogen, and from the liver as well, glycogen will go. Then the fats will start to vanish, and then the proteins will start to vanish. Okay, so that's how you see severe weight reduction. The child has very prominent ribs. You can see here in the image, the ribs here are quite prominent. You can actually count each one of them. The child is a voracious feeder. Anyone, do you know what is the meaning of voracious feeder? Any guesses? Yeah, eats a lot. The child has a lot of appetite. It eats a lot, but it is not registering in the body. That's because of organ failures and complications and metabolic disturbances that has took place. Okay, the child has a lot of hunger in them, and whatever you feed them, the child is not satiated with that, because whatever the child is being fed, it is going as it is from the intestine. Intestines have lost their maximum capacity of absorbing food. Okay, there is no fatty liver because almost all the fat deposition is taken up by the body. Okay, edema is not present here. Edema will be seen in kwashiorkor. Okay, the child has an old man-like face. You notice here the child has a. I'll show you another pic as well, that you can notice it, and also in your textbook. Okay, if you see on page number 157, those who have the textbook, page number 157, you can they have given real life photographs of kids who are suffering from marasmus. Okay, if you notice their face, it's all wrinkled, it's sunken and wrinkled, so definitely it looks like an old man's face. No hair color changes is noted here. Usually they lose a lot of hair and dry and wrinkled skin. They are alert but irritable. Okay, they cry a lot, they are alert, they know what is going on around them. Okay, they're responsive, but they're irritable. Okay, requires adequate amount of protein, fat, and carbohydrate, because you have to refill the glycogen stores, you have to refill the subcutaneous tissues with fat, you have to refill the muscles with protein. because all kind of wasting has took place here. Okay, so this is about marasmus, the clinical features of marasmus. Is it clear to all? Is it clear to all? Okay. Next, we come to kwashiorkor. Just by looking at the image, you can identify, okay, the body of this child who suffers from kwashiorkor is completely swollen up. Specifically, you notice the abdominal region. Okay, peritoneal fluid gets filled up here. This is seen in preschool children of the age 1 to 5 years, and usually most common it is seen in 3 to 5 years. Okay, what is the word meaning of kwashiorkor? Any guess? If you are previous batch students or you are repeating the class, this is a repeated class as well. So any guess what is the word meaning of kwashiorkor? It's given in the textbook as well. Word meaning of kwashiorkor. It's an African language, African word. Usually it in some slangs it refers to only elder children. In other slangs it is called as an elder child who is deceased. Okay, an elder child who has a disease. Okay, so that's when we call it as kwashiorkor. So definitely you by the name word itself it is seen that kids who are in the preschool age, okay, if it is an older segment of the age group, they usually suffer from kwashiorkor, and the younger children, usually infants, okay, they suffer from marasmus. Less than 3 years they suffer from marasmus. If the age is more than 3, they usually suffer from kwashiorkor. Okay, there is mild growth retardation, not much. Mild reduction in body weight, but protruding abdomen and subcutaneous fat is reserved. You don't lose the fat here. Okay, and protruding abdomen because of the edema, swelling. Ribs are not prominent because it will not be. When you have swelling on your body, ribs or your body prominences are not that prominent. The child has a poor appetite here, just the opposite of marasmus child. The child does not feel hungry, doesn't want anything. Enlarged fatty liver, okay, because the child is not losing fat. Fat is kept instant. Then edema is present that we can see here. You look at the legs and hands of the child, it is swollen. Moon face, a round face, usually because of edema. Okay, when you have a body swelling, you usually see your face appears more rounded. Okay, so that's a moon face. Sparse hair, flaky paint like skin. It's like flaky, the dry skin comes off. Okay, and it has a sheen. The skin has a sheen, not shine. It has a sheen. Lethargic, no energy at all. Requires adequate amount of protein. Here you can see the difference in marasmus. There is a malnourishment of protein, carbohydrates, and fat. Okay. In kwashiorkor, we have to focus more on just protein. Okay, fat is there more than enough. Carbohydrates is also not going anywhere in kwashiorkor, but protein is something we have to work on. Okay. Next, we come to a third type of severe acute malnutrition. Is kwashiorkor clear to all? Difference between marasmus and kwashiorkor, clinical features, is it clear to all? Okay. In marasmic kwashiorkor, from the name itself, it's a child who has signs and symptoms of both marasmus as well as kwashiorkor. Mostly the kids who are around 2 to 3 years or 4 years, they suffer from marasmic kwashiorkor. Okay, severely malnourished child with features of both marasmus and kwashiorkor. Okay, just by looking at the image, can you say, or reading the description given, which parts of the body is showing clinical features of kwashiorkor in the image shown? Which parts of the body is showing clinical signs and features of kwashiorkor? Yeah, legs definitely, and Abdomen, yes. Hair, skin is, yes, skin has a sheen. It has a paint-like skin. The child has a paint-like skin. Lower arms as well, not upper arms. See the lower arms. If you divide the extremities, upper arms are suffering from marasmus, lower arms are suffering from kwashiorkor. Even in legs, upper leg is suffering from marasmus, lower leg, ankles, calves are suffering from kwashiorkor. If you see the chest and the abdomen region, thoracic and abdomen region. Thoracic region, that is the chest region, is suffering from marasmus because the ribs are prominent. If you see closely, ribs are prominent. But the stomach, abdomen is protruded. That is kwashiorkor. Okay. The child has wrinkles. If it is, I don't know if it is clear in the image or not, if you can visualize it. It's not a moon face. The child has wrinkles. You can see sunken eyes. Is it visible to you? Sunken eyes, is it visible to you? Yeah. So sunken eyes is a feature of marasmus. Okay. So the child is not having definite moon face. You can see wrinkles and sunkenness very prominently, evidently. Okay. So these features of kwashiorkor are severe edema of feet, legs, and also hands, lower abdomen, lower arms, face, and also some pale skin and hair is also there. That is kwashiorkor. In marasmus, you will not see much change in the hair. There is also signs of marasmus, wasting, upper arms, shoulders, chest. That you can see the ribs as well. So this is what marasmic kwashiorkor looks like. So basically, we have three main types of severe acute malnutrition: marasmus, kwashiorkor, marasmic kwashiorkor. Okay. So these are different types of growth retardation. Okay. This is a normal child, the child who is in the center is the normal child. In stunted child, what do you see? When you compare it to the normal child, stunted child, what clinical features can you identify? All these three kids are of same age. Okay. In stunted child, what is the clinical feature you see as compared to normal child? Yeah, height is not there. Stunt means height. Height is less. Okay. Yes, stomach is swollen. Height is not there as well as weight is not there. Okay, so this is a stunted growth. The length of the child, the height of the child is not keeping up with the age as well as the weight. Okay, to a degree. Now come to the wasted part. Okay. Come to the wasted part. The child who's wasted, who's suffering from muscle wasting, what difference do you see as compared to a normal child? Yeah, marasmus in the rib cage, severe wasting. What do you see of the height? What can you make of the height? Yeah, old man kind face. Height is not impacted much when the child is suffering from muscle wasting. Height is not impacted much. Okay. So this is the difference between stunted and a wasted child. Okay. So different types of childhood malnutrition. Yeah, less hair was also there. Normal child, you can see the height. Okay. Wasted child, height will not have much impact, but the child is very skeletal, very thin. Okay. Stunted child, the child may have average weight with regards to the height, but the height is not keeping up with the age. Okay, that is stunted. Underweight, they are less to the average weight. They're quite less as compared to the average height as well. Okay, that is underweight, low weight for age. So meanings are also given under it. You can take a screenshot of it. You can understand it better. In wasted, low weight for the height. Height is okay. Weight is low, quite very low as compared to the height. Stunted, low height for the age, but weight does not have much impact. Underweight, low weight for the age. Next, coming to the changes in organs and systems. So digestive organs. As I mentioned earlier, specifically in case of marasmus, okay, the intestinal mucosa, intestinal lining, intestinal mucosa, they all becomes atrophied, they undergo atrophy. Medical professionals or people who are from science background, could you just put the meaning of atrophy in the chat box for others to know who are not from the medical field? What do you mean by atrophy? Decrease in what? Decrease in the size. Okay. Decrease in the size. So what happens is that the intestinal villi, okay, which is supposed to suck all the nutrition in, absorb all the nutrition in, that becomes smaller in size. So it will not absorb enough nutrition how it is supposed to. Okay, so that's the reason why even if the marasmic child is a voracious feeder, has a lot of appetite, but the nutrition is not entering their system. Okay, and they lose their muscle definitely. Okay, muscle tautness of the muscle is also lost in atrophy. Okay, losing muscle. And other parts of the digestive organs that get affected are your pancreas. The cells of the pancreas undergo atrophy, so you will not be secreting enough amount of insulin or glycogen. Okay, sorry, glucagon, not glycogen. Insulin and glucagon from pancreas will not be secreted properly. All the enzymes, amylase, trypsin, lipase, disaccharides, they all are reduced. The discharge of these important enzymes for digestion is reduced. So there will be no digestion. Okay. And all these things will lead to impaired absorption. The child will not be able to absorb nutrition properly. Then coming to liver. Fat will accumulate in the liver, but this happens in case of kwashiorkor, not in marasmus. And this will lead to fatty liver. Okay, fat cells, whatever the fat is available in the nutrition, in the food, it will go and accumulate in the liver as small droplets, which will lead to fatty cells. Okay, and if fatty liver, and if it is not treated, the child will go into a state of life-threatening liver failure. Okay, liver cirrhosis, jaundice, etc. And already their immunity is down, they are weak, it's difficult for them to overcome such medical conditions. Okay, next come to cardiovascular system. Heart size also decreases, that is atrophy of the heart. And if the heart size decreases, there will be no enough cardiac output. Cardiac output means heart is able to pump adequate amount of blood into the vessels. Okay, cardiac output decreases means heart is not able to pump adequate amount of blood into the vessels. So there will be reduced oxygen supply to the body. Okay, and that's the reason why this child will go into the state of hypothermia, because the blood makes our body warm. Okay, when there is low blood, imagine in case of low cardiac output, okay, not enough blood in the vessels, okay, not enough blood in the system, what happens? The oxygen levels drop. Okay, and the body becomes cold. You touch the hands, especially hands and feet of this child, it is very cold and clumsy. Okay, it means the SpO2 levels of the child, okay, oxygen saturation levels are falling down. That's the impact on cardiovascular system. Then we have kidneys. Proteinuria or albuminuria. Protein is lost in urine, that will be present. And even the filtration rate, kidneys filtration rate, glomerular filtration rate, that also reduces. So reduced urine output will also be seen, specifically in case of kwashiorkor. That's why the child has a lot of edema, because enough amount of urine is not released from the body. The kidneys have started giving up. So enough amount of urine, if not released from the body, it will accumulate, the water and the fluid will accumulate as edema or swelling. Immunological system. These are the ages where the major immunity cells and immunity organs of the body is being formed, specifically in kids. tonsils, thymus, spleen, lymphoid tissues. Okay, these have to be formed adequately so that the child has a lifelong good immunity. But because of nutritional disqualification, all these lymphoid tissues, immunological organs, etc., they will also undergo atrophy. Okay, and any organ, any tissue that undergoes atrophy, decreases in size, definitely functions will also be impaired. Glomerular filtration rate, glomerulus is a part of your nephron. Nephron is a cell of your kidney. Nephron is a structural and functional cell of your kidney. Okay, so maximum filtration, okay, filtering the blood out of waste that has to be let out. This is done in the glomerulus of your nephron. Okay, it's in the Bowman's capsule. That's the anatomy part of it. Okay, so this is where the major filtration of blood takes place. The blood gets filtered out into urine, and that's what comes out of your body. Okay. Creatine levels will be increased if there is a kidney failure. Usually, creatine levels are associated with kidney failures. Okay. Then mental development. We all know how important DHA, okay, is for the development of vision and brain cells. So mental development will be affected. Reduced glial cells, DNA, RNA, protein, okay, total lipid, whatever makes your brain cells. Brain cells are made up of fat. Okay, brain cells are made up of fat, and if enough amount of fat is not available in the, like cholesterol is not available in the nutrition, okay, DNA, RNA will not be formed, brain cells will not be adequately formed, and definitely it will affect in certain psychological, motor, as well as mental development of the child. Then hormones, please refer page number 160, table 8.2. Effect of malnutrition in hormones. Different hormones, insulin, growth hormone will decrease. Okay, growth hormone will decrease. Insulin production decreases because pancreas, cells of the pancreas we have discussed recently, they have undergone atrophy, they have decreased. So insulin production will be decreased. Epinephrine will increase. The child is, that's why agitated, anxious always. Okay. Glucocorticoid will usually increase. Renin, thyroid hormones. Thyroid hormones can go into any rivers. Gonadotropins are the hormones that lead to your lead to the health of your sexual reproductive organs. Okay, that will be decreased. So these are the effects, different effects of hormones or different effects on hormones because of malnutrition. It's on page number 160. A table is given, table 8.2. Arrows are given. Okay, downward arrow, upward arrow. Downward, which means decrease, upward arrow means increased. Okay, so based on that, you can understand what's the effect of malnutrition on different hormones, major hormones during childhood growth. Next, coming to the biochemical and metabolic changes. So protein, plasma concentration, that is the protein in your blood. Okay, essential amino acids, proteins in your blood, they definitely become low because there is very low intake of protein. Blood protein, serum proteins will also come low. And what happens is that non-essential amino acids, which your body does not require much, your body can make non-essential amino acids as it is. Your body does not require it much. That will become high. Okay, the essential amino acids that the body actually requires from food, that is not there, but non-essential amino acids, that will become high. Okay, and whatever is high in the blood, what will happen? What is the next step? Whatever goes high than normal, whatever comes into the high range than normal in blood, what happens next? Your toxicity will be there, but the first thing that happens is your body will try to eliminate it, mainly your kidneys. Maximum of the blood filtration takes place in the kidneys. Okay, so there's a lot of non-essential amino acids in your blood now when malnutrition is happening. The kidneys are trying to take up all these extra non-essential amino acids and dump it into urine. That's how you get proteinuria or albuminuria. Okay, that's why you get proteinuria. That's the definite cause of protein loss in urine. Okay, and usually the protein loss that happens in urine is non-essential amino acids, albumins. Albumins are found in your blood. Okay. Next, coming to the lipid metabolism, fatty liver is usually seen in kwashiorkor. It's not seen in marasmus. Okay, fatty liver is usually a characteristic of kwashiorkor, not marasmus. Excess fat in the liver in form of triglyceride. Okay, fat deposit, small droplets of fat will go and deposit in the liver or the liver tissue, and it becomes a fatty liver. Then carbohydrate metabolism. Blood glucose is usually normal. Glucose tolerance is also usually normal, but it may be impaired. Okay, blood glucose usually normal because your glycogen stores will try to take care of the blood glucose levels in the first few initial phases of malnutrition. Okay, after that the child may go into a state of life-threatening emergency condition where the child should be put on glucose drips in hospital, in NICU, PICU. The child will be put upon intravenous feeding. Electrolyte and water, there is definite dehydration because of diarrhea. Okay, as I mentioned earlier, what happens to the intestine is intestine will not absorb food. So what happens to the bulk of the food that has entered the body? It has to leave the body as it is, okay, without getting proper absorption. So the child will suffer from diarrhea, repeated occurrences of diarrhea, which further leads to dehydration. Okay, in diarrhea, you don't just lose water, but you lose major part of your electrolytes as well. Okay. Vitamin A status. Why is it important that we focus on vitamin A? Any guess? Why is it important when a child is suffering from malnutrition? What's the importance of focusing on vitamin A? To prevent blindness. Okay. Severe deficiency of vitamin A can lead to nutritional blindness. Okay. So we have national health programs on this as well. Prophylaxis of vitamin A is a national health nutritional program. Okay, the main aim of this program is to make sure that no child in the country, okay, becomes blind just because of the nutritional deficiency of vitamin A. Okay, when a child is admitted in a hospital or even brought to any CHC, PHC with known malnutrition, the first thing you give is the prophylaxis of vitamin A. You start the prophylaxis, that is the dose of vitamin A is given to the child so that immediate scenario of a loss of vision, night blindness, or any nutritional blindness can be eliminated. Okay. So is it clear the biochemical and metabolic changes that happens, how the pathophysiology actually works in case of malnutrition for your major macronutrients? Next, coming to the treatment part. See, when it comes to the treatment, it's good that all the nutrition and dietetics students should know, but do not take up the treatment of these pediatric cases until and unless you can answer in the chat box. What do you require here to formulate a treatment? What qualification you may require here to formulate a treatment for children who are suffering from severe acute malnutrition? Yes, you have to be a pediatrician, or at least you should be a medical practitioner. Okay. You should be a medical practitioner, at least to refer. You should be aware of this treatment, present treatment. General physicians can also provide treatment, specifically if it's a PHC and all. You get cases like this in the PHC. Otherwise, if you're not an MBBS student or you are not a pediatrician, you're not supposed to venture into this clinical nutrition. This is the clinical nutrition because the cases are dealt with in the presence of a medical team. Okay, So here you will understand the treatment in detail, because if at all you come across a child who undergoes malnutrition, even though you are not qualified to give treatment, but you can at least identify using the mid-arm circumference, etc. Looking at the features, clinical features of the child, you can identify what kind of malnutrition this is, and you can encourage them, give them health education, ask them to go and refer a clinician or a specialist. Okay. So coming to the treatment, first it's a nutritional requirement. When you get a child who is suffering from severe case of kwashiorkor or marasmus, the nutrition requirement doesn't mean that you pump up the child with food in the first day. You can't do that. You have to first look out for the life-threatening signs and symptoms, eliminate it, and then follow the nutritional requirement. Okay, so you have to if the child is suffering from kwashiorkor, you have to focus on protein. But if the child is suffering from marasmus, you have to focus on all the three major macronutrients as well as hydration. Okay, protein, fat, carbohydrate, and water, electrolytes. These all areas has to be covered in marasmic child. In kwashiorkor, you can focus more on fat control, controlled food, but protein-rich food. So whatever is the nutritional requirement you follow or you want to follow, it does not just have to meet the current status of the child, but it should allow the child to catch up with their peers. Okay, with the healthy children who are in the same age group, the nutrition plan which you prescribe here, it has to help these kids to catch up with their peers. Okay. Foods are usually rich in protein for the responsive kwashiorkor children. Where in marasmus, you have to be more frequent with the feeding. So energy, at least the child should be given 150 to 200 kilocalories of energy per kg body weight, whatever is the child's existing body weight that day. 150 to 200 kilocalories per kg body weight should be begun with. Okay. For children who are less than 2 years of age, 200 kilocalories per kg body weight can be given, and older children, 150 to 175 kilocalories per kg body weight can be given. Okay, this is how energy, this is how you calculate the calorie. What amount of calorie should I give to this child based on their age and their weight? Okay. 50% of whatever calories you give, just imagine if the child is weighing 4 kilos or 5 kilos. Okay, so if the child is 5 kilo in weight, the energy requirement of the child would be around 1000 kilocalories. Okay, so 500 kilocalories should exclusively come from carbohydrates only. Remaining 500 can be broken down into proteins and fats. So protein and fat, here you have to note it properly. Protein, 5 gram of protein per kg body weight every day should be given. Okay, this also takes care of the protein requirement as well as catching up with their peers in terms of growth and development. So 5 gram of protein per kg body weight every day. Milk protein is much better, and egg protein, egg whites. Okay, these all are good proteins which can be given. If the child is suffering from kwashiorkor, skimmed milk, go for skimmed milk. Don't go for full fat milk. Energy, 50% of the total kilocalories should come from carbohydrates. Ragi, if it is sprouted, okay, if the ragi powder what you're giving is sprouted ones, but still it's a sprouted ragi, which is dried and milled, it's good. But ideally, we will go for milk-based protein, okay, egg-based protein, because we require leucine and casein from them. These are main essential amino acids that a growing child requires. Okay, casein and leucine. This comes from dairy products and eggs. Okay. Electrolytes, the child will be put on potassium chloride or any sodium solution that will be put upon the child intravenously. And also ORS can be also a resort if the child is not having complicated severe acute malnutrition. It's uncomplicated. At home, you can give the child ORS as well to combat dehydration. Vitamins, vitamin A supplement, definitely from the PHC sub-center or from the hospital, go for it. Is free of cost. Okay, there is no cost for vitamin A prophylaxis. Free of cost it is given. Okay. Yeah, you can give coconut water as well, but ORS is preferred. Okay, because the exact amount of electrolytes requiring for that particular age is pre-calculated and given in ORS. So in a clinical setting, we'll not give coconut water, we'll give ORS. We'll go for ORS, coconut water and all. Once the child is discharged back to home, we can continue with that. So coming to the management given by World Health Organization, there is initial treatment, there is rehabilitation, and then there is follow-up. Okay, initial treatment is when life-threatening conditions, like as I mentioned, when they bring the child to the hospital or PHC, identify if the child is having a life-threatening condition or not. That is severe dehydration, hypothermia, vomiting, nausea. Okay, cardiac output has been reduced, low SpO2 levels. Okay, these all are life-threatening condition. When you receive a child with these clinical features, initial treatment means you have to admit the child in ICU. Okay, ICU care has to be given. Yeah, even in underweight baby, vitamin A supplement is important. It is given because if the child is underweight, means mother's breast milk is not having enough amount of nutrients. That could also be the reason why the child is underweight. Pregnancy also, in pregnancy, vitamin A deficiency or protein deficiency was there, could lead to underweight babies. So definitely vitamin A supplements are given. Yeah, what kind of proteins are given? We'll come to that. So in initial treatment, in hospital or in a daycare facility, life-threatening conditions are eradicated. Okay, specific deficiencies are corrected with multivitamins, with supplements, with nutritional supplements, feeding, parenteral feeding, etc. These will correct the specific deficiencies in the child, and any metabolic abnormalities, pancreas not working properly, digestive system not working properly. These all will be addressed in the hospital setting. Rehabilitation. Now the child will move to general ward. From the ICU, the child will move to general ward. Okay. Here, food will be started. Food as well as supplements will be started. Feeding is given to recover most of the weight that the child has lost, as well as the child's well-being, emotional well-being, mental health is also taken care of through food. Okay. And the mother or whoever is the caretaker of the child, they are also trained well. In what hours? Okay, we'll come to that. There is a frequency in which you have to give the feeds. Okay, within how many hours you have to give the child food. Okay, that is given in rehabilitation. Then follow up. A child and the child's family are followed to prevent relapse, and this follow up can only be done after discharge. The parents should be responsible enough to bring the child back to the hospital for follow up care. Okay, follow up takes place after you get discharged. You go to your home, but every once in a week, once in a month, or twice in a month, you are supposed to bring the child back to the PHC, CHC, or wherever the treatment was given, or wherever the case record is present. Based on that, follow-up treatment will be continued. So this diagram, this table is present in your textbook on page number 165. Those who have the textbook, on page number 165, table 8.4. Okay, you can see it this part by part. The first few days, okay, when the child is in ICU, hypoglycemia, that is too low blood glucose levels in the blood. Okay, that is also life-threatening. Your brain will shut down. If the brain does not receive glucose in enough amount, the brain will shut down. The child may go into a comatose stage or a brain death stage. Okay, so hypoglycemia has to be treated. Hypothermia, dehydration. Okay, electrolyte imbalance, any infection if the child has, immediately antibiotic therapy will also be started from day one. Okay, in ICU, because of malnourishment, infection is there, the child is coming with a septic case and all, immediately from day 1 onwards, antibiotics and prophylaxis will be started for infection. Okay, and it will continue as long as the infection lasts. Antibiotics will continue as long as the infection lasts. That the laboratory reports will conclude is the child free of infection or not. Okay, and micronutrient deficiency also from the ICU itself, ICU days itself, it will be started. But usually you focus more on hypoglycemia, hypothermia, dehydration. Okay, these are the focal point in ICU care, PICU care. Then coming to day 3 and 7, you can start, you can put the child into step down ICU or sometimes directly into the ward, depends on what hospital structure you follow. Step down ICU or HDU is used when the child is out of the critical stage. Okay, but the child requires monitoring, continuous monitoring is required, but the child is out of life-threatening situation. So you can put the child into step down ICU or HDU, high dependency unit, HD units. Okay, so there also some micro deficiencies will be corrected. Some antibiotics, if it is going on, will be continued. Okay, and you will start giving the feeding, and you will increase the feeding outside food in the sense juices, purees, etc. Because in ICU usually the child is put on parenteral nutrition, or maybe NG tube will be put. Okay, and slowly the feeding via mouth will start in the step down cases. Okay, day 3, day 7 onwards. And in rehabilitation, this is the ward phase. Here again the focus is on feeding to gain weight. Okay, whatever weight was lost, weight gain focused feeding will be focused here. Mental health development, mental retardation treatment, these will also start here. And preparation for discharge will also start in the rehabilitation phase, because from day 1 you will know how long you have to keep the child. Okay, pediatricians know how long it will take the child to respond to weight management. Okay, weight gain treatments. So discharge forms will be filled up, and within a week or so the child will be discharged to the home. And at home you can see again feeding again to increase the weight targeted weight based feeding will be continued at home as well. And if the child's brain health is impacted in any way, even in follow-up care, that has to be the focal point of treatment. Okay, so this is the treatment in brief. Is it clear to all? Not everyone has to do the treatment, but you should be aware of this is the step-by-step treatment you give to a malnourished child. What happens in ICU, what happens in wards, what should happen at home. Okay, so principles of management. First, focus on the dehydration. Here ORS solution is given, or sometimes if the child is not drinking, if the child is having kwashiorkor, they will not drink. Okay, in that case the child will be given NG tube feeding, nasogastric tube feeding will be given. ORS is preferred. The amount of the electrolyte levels in ORS is also given in the textbook. You can go through it. Okay, 70 to 100 ml of ORS per kg body weight should be given at a frequent period of 4 to 6 hours. Every 4 to 6 hours, based on the child's body weight, 100 ml or 70 ml of ORS every 4 to 6 hours based on the child's body weight is given to correct dehydration. If not, if the child is not drinking from mouth, very irritable, the child is very irritable, does not want to drink or eat or feed anything through mouth, you have to put the child either on parenteral nutrition, that is through IV fluids, or through enteral nutrition, that is NG tube feeding. Then infections, immediately put the child on antibiotics. Okay, and also antihelminthics. Okay, any idea what antihelminthics could be? Something that is very common in kids. Antihelminthics are given. Why is it given? And what is antihelminthics? Yeah, deworming. The child, children usually, not just the malnourished kids, usually worm infestation, tapeworm, hookworm, okay, ascariasis, this different kind of worm infestation is very common in kids, and with lower immunity, it is much more common in malnourished kids. Okay, so taking care of the worm infestation, deworming, using anti-helminthics and using antibiotics in case of any other infection, bacterial infection. If there is a viral infection, then antivirals should be given. Okay. Then hypoglycemia, giving milk feed, glucose in water may be sufficient. And if the child requires glucose and if the child is unconscious or has convulsions, in case of convulsions, you cannot risk giving giving the child something to swallow. Okay, because while swallowing, if the child goes into a state of convulsions, aspiration can take place. It will lead to pneumonia, other lung failures, etc. So if the child has a history of convulsions, we prefer nasogastric tube feeding, okay, or parenteral tube feeding as well. Please write down the spelling of anti-helminthics, those who are from the medical background. Hypothermia, kids who have very low body temperature because decreased cardiac output, put the child in warm blanket. Okay, do not put the child in air conditioned rooms or etc. Keep the child warm as possible. In case of small infants and all, you can use radiant warmers that are available in the NICU. Okay. In congestive heart failure, here the cardiologist is also referred. Because cardiac output is quite low, heart is atrophied, heart size is small. Definitely, there are high chance of heart failure for these kids. So urgent treatment will be started with diuretics and digitalis. Digitalis is kind of a drug that increases your heartbeat. Okay, it jump starts your heart. Digitalis. Okay, and it also increases the blood flow towards your heart, coronary arteries, etc. They get a boost of blood flow because of digitalis. Okay. Next is formula diets. This is the specific diet which is given to correct severe acute malnutrition. Okay, we have two types of formula. You can see here F75 and F100. Okay, can you guess what do you mean by 75 and 100? Any guesses? If you have read the book or if you come across this paragraph, you can find out what would be the meaning here. Yes, it is calories. Okay, it is calories. F75 will give you 75 kilocalories. F100, formula 100, will give you 100 kilocalories per 100 ml. Every 100 ml of these formulas are usually prepared in 100 ml. Okay, and per 100 ml will give 75 kilocalories for F75 and 100 kilocalories for F100 formula foods. Okay, so that's the reason why we have this names called F75, F100. One will give you 75 kilocalories, other will give you 100. So based on the child's weight, needs, okay, you can choose which formula has to be started. Usually it starts with F75. All these feeds for any malnutrition, it will start with F75. Okay, slowly you will increase the quantity. Okay. So what is in this F75 and F100? They are made up of pretty much the very same ingredients. You can see here, milk powder, that is skimmed milk powder, sugar, some cereal flour, vegetable oil, mineral mix, vitamin mix, and water to make this formula. It is same for both the formulas, but you can see slight different in the quantity used. Okay, definitely because the calorie is different. So when the kids like because of a lot of infection that the child is going through, a lot of metabolic disturbances the child is going through because of malnutrition. Okay, you start with regular diet, what is homemade, what is home cooked. Okay, any food you usually have at home, if you give the food, that kind of food to the child's body is ill prepared to absorb it, digest it. That's why we go for this formula diets. Okay, they are already pre-digested because they're milled, they're in powder form, they are in liquid form. Okay, the digestive system does not have to work too much. Okay, so easily the child will try to absorb as much as possible from the formula diet. So we start with formula diet. Once the child is able to tolerate formula diets well, slowly we will introduce home cooked meal, protein-based meal, etc. Okay. So F75 is used during the initial phase of the treatment. And where do you get the initial phase of the treatment? Where is the initial phase of malnutrition treatment is done? Yes, in the ICUs, in the intensive care units. Usually it's the intensive care units where F75 is used. And slowly when the child is showing tolerance, you will shift to F100, usually in the general wards. When the child is shifted to the general wards, you will put the child on F100. Okay. In the rehabilitation phase, you go for F100. So you can see based on the ingredients that you see here, it's readily available. It's very cost effective. And usually if it is a government hospital and all, free of cost. The treatment is given free of cost. To buy F75, F100, the public hospitals won't charge anything. It is given free of cost to the kids who are admitted in ICUs and wards. The mothers are taught how to make the formulas and at how many intervals you should feed the child. These kind of information, it is given to the mothers or the caretakers. Usually every 3 hours, 2 hours, 4 hours, day and night, even at night when the child is asleep. Okay, you have to wake the child up every 3 hours and give the formula feed and then put the child back to sleep. Okay, so 24 hours a day, this formulas, when they're put on the formulas, the child has to eat it. Even at night, if the child is sleeping, they're woken up and then the formula is given. So after this formula diets, when the child's feeding improves, okay, in admission, we have seen how formula diets are given, follow the same pattern. So after the child has an improved appetite, the child is able to tolerate F100 as well, formula 100 as well. This is the time when you understand that you can start giving home cooked meals to the child. Okay, you can understand, okay, the child is getting hungry, the child is asking for food. Okay, this is where appetite improves and you can start other forms of nutrition as well. Okay, within 1 week, the appetite should improve. In normal cases, 1 week, the appetite should improve. And this transition from the formula diet to the home cooked meal should be very gradual. Don't suddenly stop the formula and give only the home cooked meal. Don't do that. You have to make it a very easy, slow transition. The transition should be gradual to avoid the risk of heart failure, because suddenly if they consume a lot of food, large amount of food, their body may shut down completely and there is a risk of heart failure. Then deficiencies, first we have to focus on vitamin A deficiency. On page number 168, those who have the textbook, table 8.7, you can see at different age, okay, at different ages, what kind of dosages you are supposed to give to the kids, okay, in deficiencies and ages, what kind of dosage you are supposed to give to the kids, okay. So kids who are less than 6 months of age, only 50,000 IU. IU is international unit, okay. You don't have to keep a count of it because the formula of vitamin A syrup, okay, so it is available in syrup form. Also in injection forms are also available, but usually we go for syrup forms. Okay, so one spoonful of that vitamin A syrup is equal to around 1 lakh international units of vitamin A. The nurses of the PHCs and all, they are aware of it based on the child's age. They know what kind of, how much spoons of the vitamin A syrup has to be given. Okay, so less than 6 months of age, they only require 50,000 IU in the first day. Under 1 year of age, 1 lakh IU. If the child is more than 1 year of age, okay, no longer an infant, the child has to be given 2 lakh IU. That is 2 spoons of two spoonful of vitamin A syrup. The spoon that we say here, the spoon is also form a part of the packaging. Okay, you don't have to use regular spoons here. The PHC staffs, they know when they get the prophylaxis kit of vitamin A. It comes with the spoon as well as the syrup. So that a spoonful will automatically mean 1 lakh IU. Okay, IU means international units. That's usually how we keep a count of certain vitamins. Okay, just how we calculate microgram, grams. Okay, international units are for certain elements of vitamins, how to make a count of vitamins. International unit is the measuring unit. Okay. Then severe anemia, iron replacement has to be done. In some cases, blood transfusion has to be done. In severe anemic cases, blood transfusion will be done. The nutritional rehabilitation, we have just now discussed about initial treatment, rehabilitation, follow-up. The same thing you have to follow here as well. A table is also given, a picture is given, figure 8, 8E on page number 169. Please refer that. Okay. It's almost the same like initial treatment, initial phase, rehabilitation phase, and follow-up phase. So feeding the kids who are under 2 years of age during rehabilitation, that is when the child is admitted in the ward, F100 diet is given every 4 hours. Even at night, as I mentioned earlier, when the child is below 2 years of age, at night, every 4 hours, the mother has to wake up the child, give the formula feed, 100 ml formula feed of F100 to the child, and then put the child to sleep. Again, wake up in the next 4 hours. Okay. So that 1 week, the mothers may have to worry a bit about this kind of feeding. And slowly in the when you're making a transition, with each feed, like just give 10 ml of any other food, juices, purees, porridges, okay, and 10 ml, 10 ml, 60 ml, 10 ml, 70 ml, 80 ml, increase it by 10 ml, and when the child refuses to eat, you should understand the child is full, okay, and you have to stop. So you have to understand, you have to keep an eye on how much the child is eating. Just increase the feed by 10 ml only. Don't drastically increase the feed. Yeah, malnutrition, body changes are reversible. Okay. The child can gain back all the lost muscles, fat, etc. Then follow up after discharge. Give health education to the parents. Here, it's not the child, it's the parents who should receive the health education on the importance of receiving follow-up care. Okay, if not to the hospital, they are referred to the nearest PHC. PHCs are everywhere. If you're in India, PHCs, sub-centers, sub-clinics, they're everywhere, government operated, free of cost services are given here. So if the family members can't afford to come to the hospital, because usually in the socio-economic scenario, what happens is that people who are below the poverty line, okay, their kids suffer from these kind of malnutrition in most cases. Okay, so these are daily wage workers. Most of they come under the daily wage workers. They can't risk losing their day's earning or a daily wage just to bring the child to the hospital, travel far, spend money, and come to the hospital. It is they can't take that kind of risk. So that's the reason why even the PHCs, okay, PHCs, they do the follow-up care for malnourished kids. Okay, they make a note of it. They track down the kids. If the parents can't come to the PHC or the community health center, the community medical doctors or community medicine nurses, okay, community nursing nurses, etc., they can go and pay a visit to these affected households and give the follow-up care there. Okay. Suggested diet during convalescence. Convalescence is when the child has been brought back to the home, okay, discharged, brought back to the home, and the child is in the recovery phase. Okay, can't join the school yet, but the child is in the recovery phase, trying to gain back the lost strength. That is called the convalescence phase. Okay, so what you have to keep in mind here, you can give the child foods like idlis, rice, chapatis, okay,
And slowly you can increase the quantity. The first day the child came back home, you can give 1 idli. Second day you can give 2 idlis. So slowly you can increase the quantity of the food that you give. Increasing the number of meals. For example, at 6 a.m. you give something, a banana or a milk. By 8 a.m. you give something else, a handful of nuts. 10 a.m. you give something else. So increasing the frequency of meals. Okay, don't keep the child in a fasting stage. In between, always keep feeding the child something or the other, so that the appetite is maintained. Okay. Addition of oil or ghee or 1 or 2 teaspoons to increase the calories. That is, if you're cooking for the entire household, you can't risk the calorie intake of the entire household. Okay, by adding more ghee to the diet just because you want to correct the child's malnutrition. So what you can do here, before feeding the child, make sure you add a spoonful of ghee or any oil, virgin oil or any oil that is used in the household. Just add a spoonful of that to the child's serving, mix it up, and then give it to the child. Okay. Specifically in cases of marasmus, this has to be followed. In kwashiorkor, pediatrician will say how much fat has to be used. Then the child can be given a mix of cereals and pulses. Khichdi is the best option here. Khichdi, kanni, okay, dal chawal, dal bhat, okay, these are very best options here. Cereals should have 4 portion, pulses should have 1 portion. Okay, that's the kind of ratio you can follow here, 5:1. If the patient can afford milk, egg, or skimmed milk, as I mentioned, the kids who suffer from kwashiorkor marasmus, they come from a certain segment of the society, usually the below poverty line segment of the society. So affording milk, skimmed milk, egg, etc. is something that they have to think twice to spend money on, until and unless it is from ration. Okay. And they encourage the kids' family to use the services of ration shops, etc. in India, or use the services of PHCs, etc. to find in PHC ready to eat food is available. I'll come to that. Okay. Ready to eat food is available for these kids, which will enhance their weight gain. Okay. Is it clear the principles of nutrition here? What are the principles you have to follow to rehabilitate the children? So, roughed is the see, that is the reason why if the parents are not able to buy milk, egg, etc., we have this scheme going on. This is the roughed scheme. Okay? Ready to use therapeutic food. So this was made, this came into, this is a big accomplishment achieved by our National Institute of Nutrition, Hyderabad. Okay, it's they have worked on this for various many years to come to this conclusion of making an affordable, not affordable, it is free of cost usually in Anganwadis and all, it is given. Okay, it can be accessed free of cost. So it's a high energy, it's like a protein bar. Okay, it's like a protein bar because see, you can see the ingredients here: roasted peanuts, sugar, milk powder, fat, oils, vitamins, minerals, complex, emulsifiers. Okay, that is essential fatty acids, antioxidant. It's a synthesized version, not the original version. Antioxidant, synthesized antioxidants. Okay, so these are available in this roughed food. Why this is chosen? You don't have to do anything here. You just have to open the package and give it to the child. Since it is sweet, it is made up of peanuts. Children usually like it. Okay, if the child is allergic to peanuts, which is quite rare in India, it's peanut allergies are something very common in western parts of the country, part of the world. But in India and other developing countries, peanut allergies are very rare. Okay. So if at all you come across a child who has peanut allergies, etc., you can use any other nuts, ground nuts, etc., or any other nuts, walnut, or any seeds can also be used here instead of peanuts. And you can use the rest of the ingredients as it is to prepare this powder mixture. Okay, but Ruffed is available in package. Okay, it's in solid form. Nothing to do. You just have to open the package and give it to the child. The child will eat it like a chocolate piece, a bar piece, etc. Protein bar piece. Okay, so it is ready to use. You don't have to heat it up or milk it or mix it with milk or water. Don't have to do anything. Okay, and the parents can avail this free of cost from Anganwadis, PHCs. Okay, community health centers. They all provide this kind of food. So usually the Ruffed is available in gingerly oil, but based on the different states, oil may change. I'm not sure about that. And it is fortified with minerals, micronutrients, multivitamins, etc. So it is kind of an overall full package food. And one sachet of this Ruffed can give you 500 kilocalories. Give the child 500 kilocalories. So if you come from a low income family, the family is a low income family, 500 kilocalories, the child for the child is free of cost, and it is highly nutritious. You just have to take care of the other part of the calories. If it is a total 1000 kilocalorie or 1500 kilocalorie per child household, you just have to take care of the remaining part. You can depend on Ruffed for. It's also called Malai mix. Okay, Malai mix would be a name that could be more common if you have heard about it. Okay, but the original name is Ruffed, ready to use therapeutic food. Okay, it is prepared. It has came into existence after a long years of research and trial and error from the National Institute of Nutrition, India. Okay, and you don't have to refrigerate it. It's stored just like how you store a package of chips or anything out and about. You don't require any specific containers or refrigeration freezers. Nothing is required. So that's the reason why it is highly accessible and anyone can store and use it. Next, coming to the prevention. Prevention is usually done by health education given by primary healthcare centers, hospitals. Okay, it is usually focused on health education. So health promotion, educate people, educate girl childs, okay, teenage mothers, educate the pregnant women who come to the hospital for their antenatal visits. Okay, distribute these supplements to the people who are unaware. Okay, go to government schools and teach the people there. Go to daily wage workers wherever they put up their shed and work. Okay, go to these areas as a part of a community medical team. Okay, usually it is done. These healthcare camps, healthcare programs are conducted regularly by the PHCs and CHCs. Okay, they go and access all these people who do not have access to healthcare or nutrition and give them information. These things are available free of cost for you. Okay, if they are aware, they can come and avail. Okay, so that's health promotion. Promote breastfeeding, exclusive breastfeeding, low cost weaning food that is easily available at ration shops or seasonal fruits and vegetables. Improve the family diet, nutrition education, promotion, correcting feeding practices, home economics, practicing the spacing of births. At least three year of spacing should be there between two childbirths. Okay. So these are the generalized approaches in health promotion based on what kind of topic they are picking and going to do a health play or a health camp. That depends on the CHC and PHC, but usually it is around these topics. Then we have specific protection. Contain diet that's a rough diet. Okay, it is rich in protein and energy food. Okay, exclusively focusing on milk, egg, fresh fruits, etc. Wherever it is possible to keep the child, give it. Immunization schedule has to be followed for all the kids born. Food fortification. Usually nowadays you buy any store-bought oils, or you go and buy milk from outside, not from the dairy farm directly, but if you are using packaged milk, you will check that most of the packaged milks are fortified with vitamin D, other minerals, etc. Then we have early diagnosis and treatment. periodic surveillance, early diagnosis and treatment of infections, diarrhea, development programs for early rehydration. This can be achieved at home only if you identify the symptoms in the initial stage. Okay, only if the parents have the knowledge of identifying the symptoms in the initial stage, they can approach, they can go for a domiciliary care. Otherwise, if it is too critical, there is no other hope other than hospital-based care. Then we have ICDS, Integrated Child Development Services. ICDS is also a part, it's a very prominent and active part under the World Health Organizations. They usually send out money, they fund various national health